All right, and there should be a few second delay, by the way, but yes, okay. I'll let you know when it started, or I'll just, yeah.
Okay.
All right, so welcome everyone.
Right, there should be a few second delay, by the way, but
all right. So welcome everyone to the Hearts for Health first virtual shadowing session today. My name is Michael. I'll be hosting today's session. Today, we're joined by Dr. Gerardo, who is a resident physician training in general surgery. For those asking questions, we'll have a Q&A saved for the end. So again, feel free to type in your questions in the chat and we'll go through all of them during the Q&A. With that covered, Dr. Gerardo, feel free to take it away.
Awesome. Yeah, thank you guys so much for having me. My name is Rod Gerardo, and I'm a general surgery resident at Wright State University, a program in Southwest Ohio, currently doing my dedicated research at Cincinnati Children's with the Pediatric Surgery Department. And today we're going to talk a little bit about, the pathway to general surgery, a little bit about my own personal pathway to general surgery. Excuse me. And then we'll do some sample cases, and then we'll wrap it up with some questions or anything that you guys have at the end. So me personally, I chose general surgery for a lot of reasons, but if I boil it down to the two probably most, the two reasons I would say that are the most important for me when I made my decision was, first of all, in a past life, I was actually a musician. So for me, it's very natural for me to use my hands, use tools. And it just, when I got a chance to do my general surgery rotation in medical school, I, it felt so natural to me that, I was getting to use my hands to help treat a patient. And, learning from an attending was getting advice like, oh, move your finger like this. Your hand is in the wrong position, face your body this way. It just felt like when I was in, music class or something like that. The second, probably most important reason for me was, the instant gratification that you get with surgery. I am not the type of person that, I wouldn't describe myself as very patient. I really appreciate about surgery, like, someone comes in with acute cholecystitis, they need their gallbladder out. We take them to surgery, we get their gallbladder out, and then they go home, eating ice cream and they're feeling great. So I like that quick turnaround, that quick tangible, like, you did this for the patient and here it is right there, and then they can go home. But there are a lot of other reasons, and we'll get into a little bit of those as we keep going. But, surgery, when you're in medical school and you do all your rotations, like surgery is really, it's the most procedural thing that you get to do. It's the most hands-on thing. It's the most, like, I don't know, in my opinion, it feels the most like a team sport type of thing. Like when you're in the OR, you have all these different people with all this different training, all these different skills, all this different background, but everyone's working together for this common goal, which is treating the patient. So the pathways to general surgery, I'll tell you, you guys, if a lot of you guys are, college students in the United States, then you kind of know the first part here probably is, you do your 4 years of high school and then you got to do 4 years of undergraduate or college. And most of the time it's majoring in science or something else. You're expected to do all the things, you got to like find research. You have to do extracurriculars. You got to do clubs like this, stuff like this. You have to get good grades. You have to get a good score on the MCAT. The other advice I tell people when they're in college is apply early, because medical schools are rolling admission. So, try and get as much of your application ready so that for the first day that you can click submit and put some documents online and get the ball rolling. But I get it. It's a lot to do in 4 years of college when you're trying to, do a lot of your own personal growth and things like that. But I think the flip side of that is, you're only in college once. So I always tell folks, enjoy it. If you then are, lucky enough to get to matriculate onto medical school, which I don't remember off the top of my head the exact match rates from last year, but I mean, it's usually something like 40%, I think, of applicants who apply to medical school, not to scare anybody. I'm just saying, you guys know it's competitive, but it's possible. And if you are lucky enough to, matriculate onto a medical school, then the structure in the United States is pretty similar everywhere. It's, like this. It's 2 years of didactic training. It's 2 years of clinical work where you're, in the OR or doing your rotations. You get electives in your 4th year. You have to do same thing. You're expected to do everything. You have to do extracurricular activities. You have to volunteer. You got to find research. You're expected to get good grades. Instead of the MCAT, you take these other standardized tests called the USMLE STEP. It's kind of all the same kind of grind, I would suppose. It's just, on steroids. And then, you get to do other stuff. You get to do away rotations. I spent a month in Africa doing a surgery rotation out there, so you do get to get some other experiences as well. Then if you decide that you want to do surgery, then the next step, you apply to a surgery residency. And if you're lucky enough to get, admitted or matriculate into a program, then the structure in the United States is pretty much like this. It's 5 clinical years. Now, a lot of times there are programs that require research. It depends, honestly. So a lot of academic big name programs, they require you to do research, but programs like I'm in, which is probably most of them, it's not required, but it's optional. If you find funding or something, then they'll, they're going to be fine. They're probably going to be fine with you, going on and doing some research. It does help a lot of times your career if you want to do a fellowship or something like that, to have the extra time doing, I don't know, getting publications and things like that. But then a lot of the same grind is there. You're expected to do research. You have standardized tests every year. It's called the ABSITE, American Board of Surgery in-service training exam. The exams now in surgery are not just written. There's also, surgery tests. So FLS, fundamentals in laparoscopic surgery, you got to prove that you can do a bunch of tasks with a laparoscopic trainer. FES is fundamentals of endoscopic training. So using an endoscope and doing all these different tasks. And then you have your board exams. And in general surgery, when you're done, you have a written and you have an oral board exam where you have some senior surgeon grill you about different cases and things like that. So that's kind of the structure. But then, it keeps going. So then if you want to do fellowship training afterwards, or subspecialty training afterwards, then you have those options. Here's a list that I got online. Obviously, it's not comprehensive, but you can see that there are a lot of options for subspecialty training if you've completed a general surgery residency. So anything from, breast surgery to burn surgery, trauma, pediatric surgery, which is the research I'm doing right now. So a lot of different options open to you as far as different career paths in, from general surgery training. And then, then you can choose from there this is a slide I was saying that I know that list looked kind of long, but what I tell medical students is like, there's basically any organ in the body that you can think of, you can probably operate on it from general surgery training, except for bones, brains, eyeballs is usually what I tell folks, but pretty much everything else. Yeah, you can, you're trained to operate on. Now, once you do that, hold on one second. There's probably some in here, and then the lac tray I think is in the okay. So then you can choose academia versus community. What that means is you could be an academic surgeon, meaning you're a surgeon who is someone who's contributing to research, literature, publishing a lot, joining all these different clubs, like ones I have listed here, like the American College of Surgeons, or you could be a community surgeon. Those are surgeons who are just like that. They're out in the community. They're, basically maybe not working at a teaching hospital that has residents and medical students, but maybe they're just, operating all day, every day. And, they're like super skilled technicians at general surgery or something like that, but not necessarily, at some cutting edge, research institute. So then, you can get even more and more specific on the type of surgeon you want to be, the kind of career you want to build. But right now we'll take it back to, residency, what that's like. And I'll tell you the clinical side of general surgery residency day in, day out can look kind of like this. So it on a typical day, if you guys were shadowing me, it's, getting up at 4:30, getting to the hospital at 5. You're probably going to hear about the patients from the night team and start your own, what we call pre-rounding. That's basically when you go check out your own assigned patients, you're looking at labs and imaging and everything that happened overnight. You're walking around checking on them to make sure they're doing okay in the morning. And then you're probably going to get together with the team around 7 and do what we call run the list, meaning that if you're on a resident team, let's say you're on the general surgery team or the trauma team or the surgical oncology team, that team's going to be made up of residents of different levels. Everyone's going to be assigned different patients. And you're going to go through the list and kind of just talk to the team about how everyone's patients are doing, plans for today, things like that. The first cases are going to probably start around 7 or 7:30. Cases meaning operations is another word for them. So everyone's probably going to break off and go to the operating room for different cases. Hopefully, if you have time around lunchtime, you'll get something to eat, probably round with the attending or the surgeon who's training all the residents. The afternoon, you're probably doing the same thing, just getting orders, either finishing notes, any consults or new patients that come in, you're going to check them in, admit them, things like that. And then around 6 p.m., you're probably going to do sign out, meaning you're going to sit down with the team, probably run the list again and probably tell the night team, the night residents, hey, here's what happened today. Here's what to expect overnight, And then me personally, I don't like to take notes and work home. So I usually try to finish my notes at the hospital so that I leave work at the hospital and then come home and be at home, which means that then I end up staying after sign out and probably, finish your notes and everything, hopefully get out of the hospital by 7, get home, eat something, and wash, rinse, lather, repeat, all that stuff. And basically this is the schedule 6 days a week for 5 years. All right. So with that, we can start, we can jump into some cases. Did you guys have were there any questions that popped up since we're at kind of a transition point here?
So far, no questions, but we'll let you know if there's any that pop up.
Awesome. All right. So why don't we jump into the first case here? So this is a 9-year-old boy who comes in. He's got acute onset abdominal pain, meaning his abdomen just started hurting, kind of abruptly. So if we were working together, you were shadowing me in the hospital, what would that look like? And I would probably, the first thing is I would probably tell you like, hey, go check out the patient. It's what I would do first. What would you want to ask the patient? What are the things you want to ask them? Think to yourself, if you guys are listening out there on YouTube, think to yourself, what would I want to know about this patient before Rod goes in there and talks to them? And those questions are what we call getting a history. So that history, rule of thumb, you're going to want to ask about the pain, ask about the patient's own medical history, if that's applicable, things like that. And then you want to do a physical exam, meaning this kid has belly pain, then we're going to probably push on his belly and see what's going on. Okay. All right. So did you think about your questions or whatever? Well, here's what I would give you or tell you that he said. So you ask him, oh, how bad's the pain? On a scale of 1 to 10, how bad's the pain? And he says, oh, the pain is 8 out of 10. If the 10 is the worst pain of his life, it's 8 out of 10. And then you ask, well, when did it start? Well, it started about 8 hours ago. Okay, well, was it, where is it? If you had to point to it, where is it? And he said, oh, well, it started at my belly button and then it kind of moved down to my right lower quadrant. Well, he doesn't say that, but he points to the right lower side of his abdomen. Okay, so then we say, okay, well, why don't we do a physical exam here? So we're going to push on his belly, and I'm going to tell you that his abdomen is significantly tender in the right lower quadrant, and so much so that when you push on the left lower quadrant, it actually hurts on the right side. Okay, all of his vital signs are within normal limits. Heart rate, blood pressure, etc. All right, so now you have all this information. So the next thing you want to do is you want to start to put together a differential diagnosis or a list of things that you think could possibly be causing his pain. That's what we call a differential. Now with surgery, we can, kind of cheat because a lot of it kind of boils down to anatomy. So think to yourself, for any of you guys who are in anatomy, think to yourself, what is in the right lower quadrant, or that blue square in the bottom there? What organs are there? What could be causing a problem that would be right there? Because a lot of times in surgery, that's really what it comes down to. So, in that blue square, there are a lot of things that could cause pain. It could be his appendix. He has a ureter going down on both sides, so maybe it's a ureter on that side. If it was a little bit lower, especially in a male on the right side, could it be a hernia? If it were a female that I gave you in this case, then you got to think, well, there's an ovary there as well as a fallopian tube there. Could that be causing it? Similarly, anywhere else in the abdomen that could be painful, you got to think what's there. If it were the green side and he has sharp pain in that green box, then you would think like, oh, well, his stomach's there. Does this guy have an ulcer? Does he have GERD or something like that? So you kind of got to think about that to formulate your differential diagnosis and see what you think is going on. Now for this kid, let's say we get some labs. Let's say, because based on this list, we want to kind of see what's going on under there. So we're going to get an ultrasound of his abdomen there. So here's the ultrasound. So the ultrasound tech is trying to tell you, hey, look, here's his appendix in cross section. Okay, we're seeing it kind of from the if you cut it in half and kind of look down the barrel of it, and it's kind of thick. He measured it and said, hey, it's almost a centimeter. The walls are pretty thick as well. We're going to get some blood work, a CBC or a complete blood count. We're going to see that the white blood cells are 17,000. So those are a marker of inflammation, and it's saying, hey, they're a little bit. This guy has some inflammation going on of some sort, is what that tells you. His hemoglobin's 13, his platelets are 250 or something. So those are normal. So basically, you got to think to yourself, okay, here's a 9-year-old kid with right lower quadrant pain. His appendix is dilated. He has a bit of leukocytosis, is what we call it, when the white blood cells are elevated. So common things being common, this kid probably has appendicitis. So how do we treat appendicitis? In 2021, we do a minimally invasive surgery called a laparoscopic appendectomy. Basically, we go in with tiny sticks, make little punch hole incisions, basically, and go in with these tiny sticks that have tools at the end. One of them has a camera, the other one has like graspers. You could put all sorts of different things in there. And then we're going to take the appendix out with these tools. Here's what laparoscopic surgery looks like. This isn't a laparoscopic appendectomy, but it is, you can get an idea of, all the different hookups and lights and everything. And you can see the surgeon, they're not looking at the patient, they're looking at the monitor because they have a camera in the abdomen as well. So it's helping them kind of see what's going on. And if it were a laparoscopic appendectomy, this is what you would see on that camera view. That's the appendix, which is all inflamed and dilated, that worm-looking thing that kind of squiggles down to the first part of the colon there. So we're going to go in and we're going to cut that out. Now, some things to consider. Appendectomy is the most common pediatric surgical operation. So like I said before, common things being common, you got a 9-year-old boy with right lower quadrant pain, you got to think appendicitis. Now, could it be some of those other things? Absolutely. And you don't want to anchor on appendicitis, but it's probably what's going on. And now imaging. So on this kid, we got an ultrasound. In children in general, we get ultrasounds. If it were an adult, we probably would have gotten a CT or a CAT scan. The thing is, we don't like to do that in kids because it's a lot of radiation, whereas an ultrasound is zero radiation. And then there's a debate going on about whether some of these patients even need surgery at all, or if they can be okay with antibiotics and what we call non-operative therapy, non-operative management. So this is a CAT scan, the donut of truth. The patient lays on that little, gray bed part, and then they put them through that tube, and then we get a whole bunch of pictures. I tell people it's kind of like, does a whole bunch of slices, kind of like sliced bread. It'll take a whole bunch of images in sequence like that, and then you could look at the insides of the person, or like kind of like taking a piece of sliced bread out and looking at it from the side there. That's kind of like what we're doing. That is opposed to the ultrasound. The ultrasound, the way it works, I know you guys, a lot of you guys are in college and stuff. So if you guys are in physics, then the way this works is the ultrasound probe has these crystals in it, and they vibrate at a certain frequency. And then that will send sound waves down the probe. They'll hit an object. Based on the density of that object, sound waves are reflected back. There's a receiver on the end of that probe, and then it tells you, okay, here are the different densities, and that turns that into a gray scale. And then that's how we get that image that we had a few slides ago. All right, let's do another case. So case number 2. Now we're no longer at the children's hospital. We're at a level 1 trauma hospital. And we're hanging out eating ice cream when all of a sudden the pager goes off and it says the alphabet soup at the bottom here. Now these pages, a lot of the hospitals, still use pagers as a reliable form of communication, but you have kind of a character limit. It's kind of like a tweet. So these a lot of these abbreviations. So I'll summarize this for you guys so that you can understand what's going on here. What this is saying is 24-year-old male, category 1 trauma, meaning the highest level of acuity, right upper extremity, gunshot wound, heart rate is 120, blood pressure is 100/60, oxygen saturation is 98, on 2 liters nasal cannula. That's that, like if you put those little plastic tubes that they'll put in their nose so they can put some oxygen in through there to help them. And then there's a tourniquet in place in the right upper arm where the gunshot wound is. All right, so we head over to the trauma bay, and then this is what you would see. This is what it looks like in the trauma bay. You see the EMS people transferring the patient from their stretcher onto the hospital bed in the trauma bay. And then you see all the people in scrubs here. That's the trauma team getting ready to just pounce on this patient and take care of them. Now, everybody has a different role. This is doctors, nurses, residents, medical students, phlebotomists, all sorts of different team members, and everyone has a specific role. And what we call those different roles, or those different things that we had to do in the assessment when they first come in, we call those the ABCs of trauma. So our primary survey, or ABCs, what is it composed of? A stands for airway, meaning that opening from your mouth down your throat, your trachea down to your lungs. Is that patent? Is it open? Can air pass through that tube? Because if it can't, that's probably the first thing that's going to kill the patient. So if they have an issue with that, then you have to consider intubating them or putting a breathing tube down their throat so you can breathe for them, or a machine breathes for them. The B in ABC stands for breathing. So now if we get air down to the lungs, are the lungs able to expand and everything? Or is there something going on there, like a pneumothorax or hemothorax? If they were shot in their chest, could they be bleeding out into their lungs? Things like that. So then we pop the stethoscopes on, listen to their lungs to make sure that they're inflating okay. C is circulation, meaning the blood circulation. Is the patient, we're going to evaluate their heart rate, we're going to evaluate their blood pressure. Are they bleeding out? Do we need to get IV access or intravenous access? Do we need to start giving fluids or something like that because they're bleeding out from this arm gunshot wound? All that stuff. So that's probably the important thing for this patient. You guys read the case. He's bleeding out from his arm, basically. So those are the ABCs. And then you get into D and E. So D is disability. We're going to do a Glasgow coma scale. It's kind of a rough and dirty neuro exam that you could do in the trauma bay that gives some prognostic indication on how the patient's going to do. And then E for environment. So basically the thought being, so we know he got shot in the arm, but do you know that's the only gunshot wound that he has suffered? You don't until you examine the patient completely. So we'll usually cut off all their clothes, roll them to the sides. We can evaluate their back. You got to look at their whole body to make sure you don't miss anything when they first come in. Did he get shot and then he fell and stretched his arm out and then broke his hand or something like that? All the stuff you got to figure out when they're there, so you can get an idea of all the injuries that you have to take care of and put them in order of importance and which ones you got to take care of sooner than later. All right, so let's say we do all this. We find the gunshot wound, we wash it off, and then it looks like this. It's this big honking hole in the person's arm. Okay, well, let's take off the tourniquet, right? They came in with a tourniquet that was stopping the bleeding, so let's take it off. Oh my goodness, blood everywhere. Blood sprays out of the hole. It's pulsatile, bright red blood. Hits you in the face, hits the wall, hits the medical student by accident. Well, let's put the tourniquet back on. What should we do? Well, this guy's going to bleed out from his arm. Can't really tell what's going on because he's bleeding so swiftly into that wound there. So we got to go to the operating room. We got to find what's bleeding and we got to fix it. So we do that. We go into his arm, and this is a really pretty dissection. This is probably for someone who's getting a fistula for dialysis. It wouldn't look this pretty in trauma, but I just wanted to show you guys some of the anatomy here. But let's say if he got shot in his arm and you go in for surgery, turns out the bleeder was that brachial artery, the superficial brachial artery, which is, as you can see, a pretty thick dude. So if that gets injured, it's very possible for the patient to lose a lot of blood through that. How do we repair that? There's a lot of things you can do based on the injury. If you can, if it's completely broken in half, you can kind of clean up either end. And if you can get enough stretch, sure, you can put it together. If you could sew it together without too much tension, sure. If not, you can take a piece of vein and use the vein as like a conduit, an interposition. If you think of it like plumbing, if the artery doesn't get together all the way and you have a little space there where the bullet caused damage, you could put a piece of vein to kind of bridge that gap. If you can't find good vein, then you could use what's called PTFE. It's kind of like Teflon. It's a little plastic like tube that you could put there that bridges the gap. And then you could sew that in. So a lot of different options, but either way, you find the injury, you sew it back up, whatever you do, and then he's no longer bleeding out of his arm. Saved him. All right, let's do a third case. So let's say now we're out of the hospital. Now we're in clinic. Okay, so we're over at clinic, and you get this 70-year-old guy, and he wants to come in and talk to you. Hey, honey girl. It's my daughter's bedtime. She barged into the office here. Yeah, Mickey Mouse's arm.
Yeah.
Good. Good night, honey. This 70-year-old guy comes in and he says, hey, I got referred to you because I'm having bloody bowel movements. Okay. So that's the consult, or that's the reason he's coming in. So same thing. You got to think to yourself, what am I going to ask this guy when I go into the room? What do I want to know that's going to give me, the information I need to figure out what's going on and then figure out how to take care of him. All right, so we're going to go ahead and talk to him. We're going to do that history and physical like we talked about in the first case. So you pop in there and he's real pleasant. He seems like he's doing fine. NAD stands for no acute distress. He's really just chilling. He's there. He says he starts to notice blood in his stool on and off over the past 3 months. Doesn't hurt. No abdominal pain, no pain when he's pooping, nothing like that. It's just every now and then there's blood there. Doesn't really know what's going on. So we're going to do a physical exam. We're going to listen to his heart, his lungs, push on his belly. Everything seems to be normal. Because he came in saying he had blood in his stool, then we're going to do a rectal exam. There's no gross blood on the rectal exam, meaning you can't see blood with your eyes. You could also take that and spread the stool on a piece of special paper that has chemicals on it. And then from that, it will change color if there's microscopic blood that's on there. So you do that, and same thing, there's no blood on there. So then you got to ask some more questions. You got to ask about family history. Is there any family history of cancer? Are there any colonoscopies? Were there any colonoscopies? Is there any diarrhea or constipation when he has these bowel movements? You got to ask about the poop, because he says he's got a problem with his poop. So basically you got to ask all about how it is. And then what do you want to do next? Well, kind of put a spoiler in there, but in a guy like this, then the next step is probably to do a colonoscopy. The reason I want to ask about his previous colonoscopies is because if he's 70, then I would hope that he's had at least one since then. But anyway, we'll put together a differential diagnosis. And when you do that, kind of like what I said previously, is you got to kind of think, okay, what are the things that are most likely? What are the things that are probably more concerning? So anal fissures would be at the top of the list. It's very common. It's when someone's so constipated that when they have a bowel movement, the stool is so hard and the diameter is wide, so then it ends up tearing the skin, the anal skin, and then it hurts, and then there's blood in the stool at the end when you wipe. So a little bit different from that is hemorrhoids, but same kind of cause. If someone's really constipated, they're sitting on a toilet, they're scrolling through TikTok for several minutes while they're taking a poop, then the veins in your rectum, they can get really dilated to the point where they can get really big, and then they could bleed. So that's what hemorrhoids are. AVM, or anomalous venous malformation. This is like these little blood vessels that can form in the colon that could potentially bleed if they get really big, or they're very superficial as far as in the wall of the colon there, so they could bleed. Diverticulitis, that's like, if you look at this picture of the colon, you see all these little pouches or these little indentations. Again, if someone's really constipated or something, then the pressure on the wall is so big that those little areas are weak points, and they could pouch out or kind of herniate out. And then you get a diverticulosis, those little pouches could get infected, and then they could bleed or something. That's diverticulitis. And then in the back of your mind, when a 70-year-old guy comes in saying he has blood in his stool, painless bleeding in his stool, then you also got to think, does this guy have colon cancer? Now, the screening, I have to update the slide now that I'm looking at it. The screening for colon cancer, like I said, this guy has to, at least the recommendation in the United States is to get a colon cancer screening with colonoscopy. This one says 50, but I think it's 45 now. I'll have to double check, but I think it's 45 now is when you're recommended to get your first screening colonoscopy. That age for the first one, it varies based on your family history. If you have a family history of cancers or specific genetic diseases and things like that, you might have to get it sooner based on that. So let's say we do the colonoscopy on this guy. You go in with the camera, and sure enough, you see this big honking scary thing. What do you want to do? Well, you can take a biopsy of it. So colonoscopies are really cool these days. You can, it's basically this hose with a camera on it and all these different tools. You could spray water, insufflate air. It has suction, has a light. You could put little tools through it that you can control from the outside. Snares, little things that take bites of things, little grabbers. You could put a thing in there that can cauterize bleeding as well, all these different tricks. So you see something like this, you want to take a biopsy. So you can send it off to pathology is the plan. So you do that, you send off, and they look at it under the microscope and they say, hey, this is colon cancer. Well, one of my mentors in my surgery program is a surgical oncologist, and she says, name it, stage it, treat it, meaning name it. So diagnose it, what is it? Stage it, meaning how bad is it? And then treat it. because we have algorithms now these days for how to treat different cancers at different stages. So let's say we do the staging workup. So for him, you got to get blood tests. You got to get a CAT scan of his chest and his abdomen and his pelvis to make sure that this colon cancer didn't metastasize anywhere. You just to make sure he doesn't have any metastatic disease. We're going to get a CEA, carcinogenic embryonic antigen, which is like a tumor marker for cancer, for colon cancer. If this tumor is deep down in the pelvis, you could consider getting an MRI, so you can get a better visualization of the tumor. And let's say finally you get the actual stage of this cancer, and we're going to say it's T3, meaning T for tumor, N for lymph nodes, and M for metastases. So he has a T3, N0, M0, meaning T3 is how deep the cancer goes as far as the layers of the colon. N is he doesn't have any lymph node metastasis, and he doesn't have any distant metastases. The cancer hasn't moved anywhere else, like in his lungs or something. So how do we treat this in 2021? Well, we do another minimally invasive surgery. We do a laparoscopic sigmoidectomy. So basically, cut out, if this guy had cancer in a sigmoid, we're going to cut out his sigmoid. Now, the way we cut out the colon, like if he had cancer anywhere else in his colon, the way we cut it out or decide how to cut it out is based on the blood supply. Because if you don't have blood going to that colon, it's going to die. So you have to base the part that you're cutting out is based on the blood that's feeding that section. So for this guy, let's say he had his tumor was in his sigmoid. We're going to cut it out based on the blood supply to that area. So this vessel here, the bigger one, this is the inferior mesenteric artery. But if you want, you can cut out the sigmoidal arteries and take out that piece of colon specifically. And then we put the other pieces of colon back together. And then this guy's probably going to get chemotherapy as well. All right. So that's my third case. So to close out the rest of this PowerPoint, I'll tell you a couple of things here about my thoughts on other things in surgery. So first of all, success in general surgery. I think there's two parts. The first part is success in the operating room, meaning, are you skilled as a surgeon? Are you good enough with the actual task of surgery to perform an elegant operation so that the patient doesn't get any undue complication or harm because of a technical error. And then there's the other side of surgery, which is success outside the operating room, which may or may not be more important, is not just how you operate, but how you talk to the patient, how you decide the right surgery to do, how you decide when not to do surgery, and how you take care of that patient before and after surgery. That's the other key component of being a surgeon that you have to master. I think both are pretty important. Some people are strong in one side or the other, but really, I think you got to kind of be both. And the other thing, pros and cons about general surgery. So I put on here some of my favorite TV surgeons, which, it's funny to watch and kind of make fun of and stuff like that. But, a lot of stereotypes in surgery are there because they're, I think, rooted in some sliver of truth. Some of the things that, you see on TV, come from some sort of reality in general surgery for residents and trainees. So one that I tell people is general surgery, I think, is one of the specialties that is very, very close to life and death. Every time you take a patient to surgery, they are at risk of dying, even of just the anesthesia, let alone the procedure that you're doing. Patients could bleed out, patients could get infections and get really sick. So it's just one of those, it's one of the professions I think that is very, very close to death, so that's something to consider. The other thing is, it's kind of like a double-edged sword. They're also really great saves. Think about those patients who come in with a gunshot wound in their abdomen and they would die otherwise, and you go in, you do the right surgery, and you save the patient. Or that patient who had, in the case, who had cancer, a patient who has a disease that could kill him, and you go in and you do the right surgery for him, take care of him, and then he lives, so it's that double-edged sword. The second thing I tell folks is time, not just time as far as hours in a day, because I showed you guys that slide of what like a typical day for a surgery resident is. It's a lot of hours every day, every week for several years. And then on top of that, it could be even more years depending on what you want to do. It's like I'm doing 7 years of general surgery residency, and then I'm going to do subspecialty training afterwards. I'm going to do a fellowship afterwards. So that's a lot of years total of my life, that I'm putting towards this. So you have to consider that, when you're going into this. And then, of course, the other thing I said at the beginning is the careers in general surgery. There's so many options for what you could do when you have general surgery training, not just as far as fellowships, but then what kind of surgeon you want to be, what kind of practice you want to have down the road. You have a lot of different choices out there. So that is the gist of my talk here. I put my social media handles here as well. If you guys want to reach out to me or anything like that, feel free to shoot me a message. But otherwise, happy to answer any questions or anything at this point. Thank you guys for having me.
Definitely. Well, thank you so much, Dr. Dr. Gerardo, for coming on. Our first question that we do have is kind of referring back to your earlier case. You showed that dissection. It was pretty nice, pretty detailed too. So in terms of the actual the surgery, how do you exactly know, although this is a pretty general question, is there a general guideline behind how you know where to cut an arm so you don't end up, cutting off an artery or vein for more blood loss that's not needed, incidental blood loss?
Yeah, of course. I think so. There are guidelines for this. It's called what is it called? It's called the ASSET course, surgical something. You know what? Don't quote me on this. I know this is getting recorded. Google it afterwards. It's called ASSET training, but they do this special like trauma surgery training for the types of incisions that they recommend based on the injury pattern that you're presented with. So, if a patient is shot here, then this is the incision you do to get to the specific anatomy that you need to see. And it's for everything. It's, for arms, legs, groins, chest, abdomen, you name it. They have all these different, it's like these different recommended dissections based on what type of injury you see. So for that, based on, obviously there's some variability based on, where the gunshot is or where the stab wound is. But the fact of the matter is, regardless of where the gunshot is, the anatomy that you want to see under that. And if the patient wasn't there for a gunshot wound, what's your surgical approach to those arteries, those blood vessels? That's the route that you want to take. So for this patient, if he got shot in his arm, you would know the anatomy that you want to see, and that's going to guide your incision. Not necessarily like, oh, here's a bullet right here, so I'm going to, try and cut around where the bullet is. That's not necessarily the goal, because it might not give you the best dissection based on the patient's anatomy where that gunshot wound is. Hopefully I'm making sense. Did that make sense? I hope that made sense. Hopefully I answered your question.
Yeah. So our next question actually also has to do with the case reports, but more specifically to the age groups, the demographics behind them. How would your diagnoses, or would they even differ at all, based on certain age groups? So for example, one of them was a 9-year-old. Would your diagnosis have any variation if, for example, they were more elderly? And what would those variations be?
Yeah. So certainly when you are putting together your differential diagnosis, you have to put together all of the information that you collected, including the age of the patient, whether they're male or female, all those things play into it. So for example, that 9-year-old kid, common things being common, you got to think of like the things on that list, the appendicitis, inguinal hernia, et cetera. If a patient, the patient who was 70 years old and had the bloody bowel movements, same thing. My differential diagnosis for someone in their 70s who's having stool problems is very different from someone who's 9 who's having stool problems. You got to think it's years of constipation that get you to the point where you have hemorrhoids, or it's years of cancer growing in your colon that would get you to the point where you have a big ulcerating tumor like that, versus a child who has a bloody bowel movements. And I think, oh, well, this kid's probably has an anal fissure, probably just is constipated and just cut the anal skin by chance when they were having the bowel movement. I wouldn't think that a 9-year-old kid would have colon cancer necessarily. So the age of the patient certainly has a big weight on the diagnosis that you give them, because you want to try and use all that information you can to come up with the right diagnosis.
Definitely. And then we have also another question, more so in comparison to other specialties. So compared to non-surgery, is misdiagnosis less problematic to deal with, for the reason of being able to deal with real cause in the OR and correct it accordingly? So in the OR compared to non-surgery specialties, because you are there able to treat things in the moment, is misdiagnosing something less problematic compared to medicine, where the patient goes home, gives their own treatment by themselves, and follows up later?
I mean, yes and no. I think that every specialty in medicine, no one's ever 100% right all the time, every time. Everybody makes mistakes because we're human. I hear what you're saying, that there are certainly instances where you think something's going on and you go in the OR and you find out something else is going on because you're right there, and then you can kind of adjust accordingly if you have to. But at the same time, I would argue that surgery sometimes will, kind of like what you said in that question. I mean, surgery can sometimes do the same thing, as misdiagnose and send someone home, when they have some sort of surgical issue or something like that. I think we're all at risk of doing that. And the best you could do is, the only thing you could do is your best, I guess, would be my advice, regardless of what type of specialty you go into. You could just all you could do is your best at making sure you get the right diagnosis and make sure you get the right treatment for the patient. But, certainly, because surgery is the way it is, if you go into someone's belly because you think, one thing is going on, something else turns out to be going on, you're right there. And certainly you could fix something if that was included in the consent for the surgery. But otherwise, I don't think it's necessarily unique to surgery. I think we all kind of can fall into those same traps.
Definitely. And kind of branching off of that point, before you did eventually dedicate yourself and choose general surgery as your training path, were there any other specialties you were considering? Internal medicine, other branches of medicine that you're considering during medical school, or even before that?
Yes. I actually went to medical school to be a pediatrician. So I, totally different career path than surgery. But I don't know. I think that it's certainly good to go into medical school, like, with goals and things like that, and to have an idea of what you want to do. But the fact of the matter is, you really don't know until you do it. You really don't know until you're on that rotation and you're doing, surgery, that you're like, oh, I love this, or I hate this, So I would advise people to have an open mind with everything moving forward with medical school and otherwise, because you really don't know until you're in it. So try and get as much experience as you can, shadowing or volunteering in the hospital, seeing as much as you can before you get to medical school. But, I don't know, when you know.
Definitely. I guess it's kind of a passion thing. You see it, and you realize it's a thing for you. We have also another question, more about the actual patient cases, the operative care. When you do look at the recovery stage of things, what does it look like, especially for tough cases, when the surgery already didn't go too well as it was expected? When it does come to recovery, are there any precautions you might take that are extra? Are there any examples of those kind of scenarios where surgery didn't go exactly as planned, but the patient is still in that recovery process?
There's a lot of variability in that. I would say that, a tough case, let's say, for example, a tough laparoscopic appendectomy, the patient is probably still not going to be in the hospital for that long versus a tough, pancreatic resection for pancreatic cancer or something like that. Is the recovery is obviously then much more prolonged and much more complex. So some of it kind of depends on the surgery that was being done. A tough case for a tough version of one surgery can be dramatically different from a tough version of another surgery. But I can tell you that there's certainly, instances where a surgery doesn't go quite as anticipated because of, multiple issues, patient's anatomy, or the tumor or lesion didn't quite end up looking the way that it did on imaging when you finally get in there or something. All these different things could happen. But the phase after that, the recovery phase, in general, this gets back to the one of the points that I said at the end of the presentation there is the surgeon has to be good at the stuff outside of the OR as well, and anticipate if you have this complication, this is how I take care of it afterwards in the ICU. This is how I take care of it afterwards, manage it, as an outpatient and things like that. You have to know enough about the surgery that you're doing to know what can go wrong and what to do when it goes wrong. So anyway, I don't have a great answer for that. A lot of variability.
Yeah, and it's understandable. Each patient is different. So going to your training, you just dedicated 2 more years on top of the already 5 years of general surgery to clinical research. What went on behind that decision? And moving forward, how do you hope to use your research experience that you are gaining through these extra 2 years of clinical research?
Sure. I'll tell you that I didn't initially plan on doing extra time to do research, but it came to the point where an opportunity came in front of me where I got to work with a surgeon who I think we have a lot in common, and he has a lot that he could teach me about my own interests in surgical education and things like that. So it came down to I appreciated that about the specific lab that I got to be a part of. And then on top of that, I realized that I think I want to do a fellowship, and the extra research time does make you more competitive, for application for fellowships, because then you'll have, ideally more, publications. You have under your belt, you could say that you learned XYZ skills, in your time off. You make connections with surgeons at different institutions when you're in your research time. You get time to go and present at conferences and things like that. So there's a lot of opportunity for career growth when you take 2 years outside of the operating room and you get to focus on these other sides of surgery. So my hope is down the road to get to use some of these these skills that I'm using, and I think that being able to critically evaluate research and perform research in and of itself is a skill that everyone could take time learning. We're MDs, we're not PhDs. So the ability to accurately, critically evaluate research, I think, is a skill that we have to do in practice. So I would hope that extra time like this, where I'm reading journal articles every day, you get better as you keep doing it day in, day out.
Definitely. And moving forward you've already had, like you said, 5 years of general surgery, 2 years, or you're hoping you finish off your 2 years of clinical research. Moving on to fellowship, what also inspired you to continue your training from there? Was it a specific, passion for one thing or another, and what might have sparked that?
Yeah, I think that I am fortunate enough that I work with a lot of surgeons who are subspecialty trained, and I think I like the idea of being a little bit more niche with your surgical practice. Now, I wish that I wanted to be a community general surgeon and just do any and every surgery under the sun, at some community hospital. But for me, I don't think that I don't think I want that for myself. I think that my personality and everything, my own personal interests that I've noticed in myself, like, I think I'm more the type that I want to get really, really good at a specific type of surgery, rather than some of these really talented general surgeons who, they can go from in the morning, they're in someone's abdomen doing all this, intestinal surgery. And then in the afternoon, they're doing a bypass in someone's leg, that the ability to shift back and forth like that, I really admire, but I don't think that's me personally. I think that, my own, my own focus and everything, like, I feel like I'm more the type that I just, I want to be really, really good and repeat doing very, very similar things over and over again, and then just become really expert at those. And then the other side is I think that I do want to be an academic surgeon. And oftentimes, this is a stereotype. I think it's a generalization. It's not necessarily true, but oftentimes those subspecialty trained surgeons are the ones that you'll come across at large academic institutions, those big name hospitals and things like that. Because that's what those hospitals want, is they want to have, a pancreas surgeon. They want to have, specifically a foregut surgeon, specifically a vascular surgeon who does just aortas, like that kind of niche subspecialty thing. I think that is what I want in my career. Things might change, still figuring that out, but that's kind of my thought.
Yeah. And speaking of niche, there's a lot of, to your point, a lot of hospitals, academic centers, just in general, healthcare facilities that are looking for those fellows, residents, and attendings that do have the same vision and view. I'm sure that you probably have seen that maybe when you are having your own interviews, maybe seeing applicants or residents come into the program. So could you speak on that for the pre-medical, pre-health students who have medical school, residency, possibly fellowship ahead for them, where they're going into those interviews, they're not exactly sure what should I focus on within the interview. They have so much to talk about, but a limited time to express that. And they want to match that vision that the institution has. So what is the kind of, first of all, research that you would want to do into making sure that you're a good match for a certain institution? And how do you bring that across in the interview?
Yeah, it's tough to balance. You want to go into these interviews and almost like, sometimes you feel like you want to say what they want to hear, but at the same time, you have to stay true to yourself. You have to be yourself. You have to be honest with them, because, you don't want to necessarily lie to a program just so you can get in, and then you get there and it turns out you're not a great fit. It's like, oh, well, because they thought you were someone else. I think that there's definitely research that you should do when you go into an interview. You should know, about the school, look at, what are the percentages that of different specialties that their students match into after, is this a place that's making surgeons? Is this a place that's making primary care doctors? What are the extracurriculars look like at this place? What opportunities they have for different clubs that you're interested in? Look at the faculty. Are the faculty doing things that you like? Are they people who are out big leaders in medical societies or researchers and things like that? There are so many things that you can kind of tailor to. If you're lucky enough to have multiple medical school interviews and you could be a little bit choosy, then certainly, kind of take a step back and look at all these things. The other thing is, and this is probably hard with COVID, unfortunately, but, when I was interviewing, I would take like not a day beforehand, but an evening or something beforehand, before the day before the interview, to check the city out. Is this a city that I could see myself living in? spending time with the medical students on the interview day and seeing like, do I vibe with these people? You know, are these people who I can relate to? You know, are they like me or no? And I don't know. These are questions you have to answer yourself when you're going through the process. I ended up doing a second look at my medical school too, which I don't know if they're offering those because of COVID, but you would basically go back a second time and you do almost like a second tour day or something, or an interview day, not an interview day, but you go and you get to talk to more people and meet more people at the program to see if this is really the school you want to go to. So I don't know, my advice is yes, do the research on the program, figure out what the program's about. On interview day, you know, I would advise you to be yourself, have that understanding of what the strengths of the school are, but you ultimately got to be yourself.
And just to wrap up our session with, again, the audience being pre-medical students, pre-health students, people who are just maybe interested in the specialty in general, any last words of advice you have before we wrap up?
Just enjoy college is my advice. Enjoy your time because, you know, you're only in college once. And when you get to medical school, it's a lot of work. It's a lot of fun too. I enjoyed it and everything, but you know, it's very different as far as, you know, you're spending your weekend studying versus, you know, in college, you're going to football games and all that stuff. So I would say enjoy your time as an undergrad, because you're going to enjoy your time as a resident and a medical student and et cetera, but you know, it's just not the same. So I would advise people, you know, for your own well-being, honestly, for your own mental well-being, you know, get away from the books every now and then and do something fun for yourself with your friends, something non-medical with your friends.
Definitely. Well, I think that wraps up today's session. Thank you so much, Dr. Gerardo, for coming on, taking some time to join us. And for our shadowers who are listening in, we just posted the link for our quiz in the chat. It's also on our website, on our virtual shadowing page. The quiz is going to be due at 11:59 Central Standard Time on the following Wednesday after virtual shadowing session. So it's going to be November 24th, Wednesday at 11:59 Central Standard Time. Be sure to keep a lookout for our next virtual shadowing session, which is going to be with Dr. Scalia on Thursday, December 2nd at 7 p.m. Central, or in this case, 6 p.m. Central. So Dr. Scalia, Thursday, December 2nd at 6 p.m. Central. And again, our quiz is there either on the chat or on our site under the virtual shadowing page for you to fill out and have your credit for attendance. Again, the minimum score is 60% on your first attempt. Again, thank you so much, Dr. Gerardo, for joining us today. And thank you all for joining and listening to our virtual shadowing session today.